evening. Thank you for having me, Dr. Hood. Thank you for inviting me here. So I'm going to talk to you a little bit about why I came to medicine and what I'm currently doing in the School of Medicine. So this is a picture of me and my family at white coat ceremony. It's when we get our official doctor coat. And I wanted to start with this because I've heard Dr. Jones's talk before, and I think that my family really represents the rich soil that has let me as a pink flower really blossom. And along with other support of Dr. Hood and other faculty members, Dean Willies Jacobo, et cetera, has really blossomed that to make me be who I am right now. So I wanted to do a shout out to my family. So this is Washington, D.C. This is where I'm from. I'm from Prince George's County. And I'm showing you this map because my commute to school every day really determined why I wanted to go into medicine. I commuted from Prince George's County, which is the most affluent Black county in the nation, with around 60% Black residents. I drove, I didn't drive, my parents drove me through southeastern San Diego, southeastern DC. Same thing, same exact thing, yeah. So up to northwest, exact same thing, La Jolla, DC's version of La Jolla, every day. And I saw the ghettos every day. I saw Black people waiting in line for food stamps at 7 a.m. while I'm driving to this rich private high school on the hills where, you know, the son of AOL's founder was going there. And I'm seeing this every single day, and I'm thinking, why? What's going on here? What are these health disparities? What's happening? And then in high school, I was fortunate enough to volunteer at an inner city hospital, Washington Hospital Center, which is right around here. And I saw the product of these health disparities. I saw the health outcomes of these equity disparities, the Black diseases, that in the hospital it's a little too late sometimes to make any change. You don't have any prevention. And so here's a map similar to Dr. Eiten's work that does life expectancy and geographic mapping. And so where I'm from, Prince George's County, it's 78 years, versus up in Montgomery County is 84 years. And this is still the most affluent Black county in the country. That's not similar to a very low income area as well. So we're talking about poverty and whatnot, but at the same time it still is race. Even though I'm coming from this affluent area, I'm Black. It doesn't matter, I'm Black. And I have the same health outcomes no matter what sort of income level or whatever I came from. Anyways, so this is what I was seeing in the hospitals. There was a lot of gun violence that was happening in the hospitals as well, and one that particularly hit home, a family friend of mine, an African-American man, was shot, and I visited him in the hospital. As I was volunteering in the hospital to prepare for college, he was struggling for his life. And he unfortunately passed away, and it was just interesting, just seeing the differences. Someone who I'd grown up with, and my parents are getting ready to take me on a college tour of Dartmouth and Brown, and This set of parents is getting ready to bury their child, their 19-year-old child who had the same capabilities as me, the same desires as me. So that really, that story, that commute, that experience really wanted me to go into medicine and to go into prevention and into public health. Because in order to make true change, you have to work beyond the confines of the hospital. It's more than just treating the patient. We have to address this, that it's too late to address it when we're in the hospital. So that's, thank you. So that's my reasoning for wanting to come into medicine. And now I'll talk to you a little bit about what I have been doing in medicine. So I'm a part of the PRIME program, Programs in Medical Education, Health Equity. And it's a little bit cut off, but its mission is really to focus on the communities that are really underserved and using interdisciplinary and multidisciplinary approaches to tackling health and prevention, and preparing physicians to be very culturally sensitive to treat those underserved communities. And with PRIME, we do a lot of mentorship at Lincoln High School, which is right down the street. We do a lot of mentorship with the high school students there. PRIME students are really involved in free clinic. UCSD is known for its free clinic. Border health projects, providing free care to individuals who don't have access to care, who don't have the income for care. I'm also a part of the Student National Medical Association. So this is the SMA, which Dr. Hood was a former president of, the National Medical Association. And as you can see, it's a pretty diverse group of people we have here. And we're also really involved in mentorship and increasing the numbers of underrepresented minorities in medicine, URMs, as we like to call them, because they're around, the national average for African Americans is 12%, and the national average of Black physicians is 6%. So, we have to do double, 200% to get to the level of where we need to be, so that the people that we want to serve can see us. Because right now they really can't see the Black doctors. They see Dr. Hood, they see Dr. Butcher, they see Dr. Aflalo, but there still are more. And this is also the Medical Students for Justice. So this is a group that came out of the White Coats for Black Lives Matter, And this is sort of the end of Dr. Kamara Jones's speech about what we do next with racism. We name it. I forgot the other. What was it?
How is racism operating here?
Mm-hmm.
And then organize and strategize to act.
Organize and strategize, right? So this group. This is an interdisciplinary group of all minorities, all oppressed groups. That's really focusing on those three strategies. And right now we're kind of in the third aspect of strategizing. We've named it, and we're doing the second step, and we're now ready for that third step. And so over the past year with the police brutality issues and the White Coats for Black Lives, we had a protest. And we had a die-in. We had a white coat die-in. And I was really impressed by the community. I was really impressed with all the students that came to support this effort, that racism is killing Black people, that police brutality is killing Black people. And so this is the group of students. So we're students who are aware. We are aware of what's going on, and we are ready to make change and engage. And I just wanted to highlight something that we also recently had, Making Medicine Equal Conference. This is a conference that Dr. Hood spoke at, Dean Willies Jacobo spoke at as well, that talked on a several different types of topics, health literacy, access, allostatic load. And one workshop that we worked on was uncovering implicit bias. So we had mentioned briefly about implicit bias, unconscious bias. And we know there's explicit bias that's straight racism, blatant racism. You don't come in here because of your race. And then there's the implicit bias, the microaggressions, that the perpetrator really doesn't know what they're doing. So we created this workshop to really talk to medical students to try and help them uncover their implicit bias so that they aren't then affecting the health outcomes of others. So this is a little busy of a slide, but it's how bias causes discrimination or disparities in health. And there's the top one here is the persistent discrimination, these 3 levels of discrimination that Dr. Kamara Jones was speaking about. And this also physiological stress that I'll talk about a little bit later, this allostatic load that affects health disparities. What Reverend Brown had mentioned of feeling stress when the police come up and how that had a detrimental effect to his health. The next 2 aspects that medical students can really change and make an impact on is physician implicit bias. There have been many studies that have been shown that there is preferential or differences in treatments and aggressive treatments, treatment options, screening practices based on the race of the patient and based on the race of the provider due to implicit bias. Oh, I see you're black. Oh, you're probably poor. I'm probably not going to give you that the more expensive type of medication. Or, oh, black men don't really, they're pretty homophobic. I'm not going to give them a prostate exam. I don't really want to do that. So those are other issues that can affect health, and that's something that medical students are trying to work on right now and trying to uncover that implicit bias. And one of the ways that we do this is with the IAT, Implicit Association Test. This is the most well-known and well-used test to uncover implicit bias, and it's a repetitive matching of I'll use the race instance of black and white, of good and bad and black and white, or white and black. And you click it, and you subconsciously click back and forth, back and forth. And that can kind of tell you your implicit bias. And it says preferential treatment towards whites or preferential treatment towards thinner people relative to obese people. And I took this test for Prime, for the program, for our orientation, and I was coming back from Zambia, and I had grown my hair out, natural, and I was Black Power from Africa, taking this test, and I get a moderate preference towards whites. And I was like, what? This test is flawed. I take it again. And it's a slight preference, but it still is a preference towards whites. And I'm thinking, what? What is going on? I love black people. I love me. And if I have bias, everyone has bias. White people definitely have bias. There's this, and I think that test result really hit on the internalized racism. It really spoke on the internalized racism, on the being the only black girl in a predominantly white school, at that school on the hill in the white part of DC, and feeling pressure to live up to the positive stereotypes of being black, but not doing the negative stereotypes of being black. Being called whitewashed to the black friends that I had in Prince George's County in the black part of DC because I was getting educated. still struggling with that. It's tough. But you talk about it, and who knows? And maybe, that bias could have been affecting how I treat Black patients in the future. And if I hadn't have taken that test, who knows? I don't know. Okay, so now I'm going to talk to you a little bit about my a project that I'm doing with Dr. Rodney Hood. Sorry, I'll be really brief. I apologize. But it's how racism is a contributor to allostatic load, explaining the cardiovascular health disparities among African Americans. So the background for this, I was listening to a talk with Dr. Rodney Hood about post-traumatic slavery disorder. And he brought up this cardiovascular risk estimator, and it has race as a risk, as a health risk. And you click on Black versus white, and your chance doubles. Your risk for having a cardiovascular disease doubles. And this is kind of a slide of telling the disparity ratio that Dr. Hood put together. That African American women who are in the 40-year-old range, they have a 20% risk of cardiovascular disease compared to white women who have around a 4.6 risk. Getting to Black women have 4.5 times more likely a chance of having cardiovascular disease relative to whites. And so why is that? Why is race a risk factor? So we know that there's health disparities within the Black population. Heart failure is 20 times more likely in African American men and women in their 30s and 40s compared to whites. And also this is being seen in San Diego County. The rates for cardiovascular disease within the entire San Diego County is around 100 per 100,000 versus in southeastern San Diego, it's around 180 per 100,000. So we know that there's something that's going on within our local community as well. So what could be causing this? It could be genetics, it could be our race, but as Dr. Hood said, we're all just a mix of different races, and if race is a social construct, then how is race affecting it? Is it access to care? Is it insurance? Maybe. But there's this other theory called allostatic load, the wear and tear on your body over time due to stress, due to chronic exposure of stress. Rather that be your occupation. No one really likes their boss, but maybe. But usually your job is stressful. Could it be children? I know I'm stressful to my parents. Financial pressures. But what if it's racism? What if it's personally mediated, institutionalized, or internalized racism that's causing a stress, that's causing a stress effect, that's raising your blood pressure, that's increasing insulin resistance, which means that you're at a higher risk of getting diabetes and higher risk of being obese. Cortisol, this stress marker, also decreases your immune system. So all of these things, this body of being in this constant stress, this constant overthinking, it can really have some physical effects on your health. So our objective is to look at the effects of racism and cardiovascular disease, and just to go through. So there's a couple of surveys that capture racism, and that's kind of what I've been working on over the summer and during this first quarter. And so there's a couple ones that that Dr. Hood and I have decided to use. The first is the scheduled racist events. And this was made in the mid-1990s. And it's to assess the frequency of racist events within the past year and within the lifetime. And also, how did you perceive that as being stressful? So one example is, how many times have you been treated unfairly by institutions, schools, universities, law firms because you are Black in the past year, in the entire year, and how stressful was this for you? So there's 18 questions of that. There's the index of race-related stress, another survey. And some examples are, while shopping at a store, the sales clerk assumes that you can afford certain items. And how stressful is that for you? And last one is the adverse childhood experiences a survey that really looks at some of the experiences that we've had below the age of 18. That look at physical, verbal abuse, sexual abuse, neglect, alcoholism, incarceration within the family, and how that also has some effects with our health, have increased risks in cancer and autoimmune diseases, lupus, etc. And then lastly, there's the resiliency questionnaire to see if there's any sort of protective measures. And one such question would be, when I was little, other people helped my mother and father take care of me when they seemed to love me. And they seemed to love me. So these are just some examples of questions that we're going to have in our survey that Dr. Hood has taken. And here's a flyer of our project. If anyone is interested in participating, please let me know, or let Dr. Hood know, or let Dr. Bustos know. And that's it. Thank you, sir.